majority here. Okay, I'm going to ask the speakers from the first two sessions to come forward to the table. We're going to have a few minutes to do a brief Q&A. Please direct your questions to an individual if it's a specific area that you need information. Also, please understand that we don't have a lot of time. I think we have, our cutoff is at 9:15, 5 minutes, yeah, to cover this. We'll see how time goes toward the end, and accumulative questions might be answered later. Bob, looks like you're number one. Go ahead.
All right. Good morning, Bob Thompson with EPA. Question for all the speakers, I think. I noted that you talked about needing a definition of health, and that several of the presenters talked about social as well as, of course, the physical and mental health aspects. Is it the intent to also cover more of the World Health definition of health, which is inclusive of well-being, which gets into things like productivity in the workplace, performance in schools, some of those factors and metrics that are so critical?
Yes. In fact, that's what we're working from, is the World Health Organization definition.
If I may be so bold to suggest maybe that be very explicitly listed as some of the items as part of health, covering the performance and productivity impacts.
And it's also a great point, too, because a lot of people, when they think of health, they think of lack of disease. And so really changing that, because how we study wellness and stress is different sometimes depending on if we're looking at wellness or if we're looking at disease. And the statistics and the models and how we study that is also sometimes not always complementary. So I think that's a major challenge and a great point. So thank you, Bob.
And it's also how we study buildings. Bob, you know as well as I do, we started in buildings, sick building syndrome, and that's all we did was sick. And so none of us ever walked in a healthy building, and that's part of the problem. We don't know what's healthy, because we've only studied sick. So we need to change our attitude. We want to move towards the positive. How do we make people healthy? How do we make buildings healthy?
Anybody else?
Yeah, if I could comment.
Go ahead.
I think that it's a dramatic effect when I work in my clinic now, where the air is filtered by charcoal air filters, and I have tile floors and non-toxic paint, and the patients who smell like perfume or detergent have to wear scrubs and get out of their clothing so that they don't make other patients feel sick.
Right.
I am extremely productive, and I never get tired. I can go till 8 o'clock at night and then go ride a horse after that. So the amount of energy somebody has when they work in a clean building and the lack of disability is tremendous. And we just didn't have time to really go into great detail, but that would be the main financial pitch in the short term for architects and people building buildings.
Okay.
And can I just add, I'm just going to kind of put a challenge out there. I just came from the TED Med conference, and that was a really exciting time to look at how we're capturing data differently. And so sometimes we talk about the built environment in buildings, we think, oh, it's up to design, it's up to the people that are operating and the facility managers, and then it's certifications, it's them. I'm different than the building. And looking at new ways to capture some of the subjective data about the actual person and how we can monitor how they're using the environment, how they're interacting, what they're doing, what they're breathing. I mean, this is not so far out there that we also put the onus both on the individual to understand how you're interacting, because a lot of this for people is invisible.
Okay, Jonathan?
I'm Jonathan Hers with HHS. I want to ask a question I hope will be a recurring theme today. I think most of us here are pretty convinced about the health hazards of the built environment, and I hope people can talk about what the barriers are and resistance. How could anyone possibly oppose this sort of approach?
Money, 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 money. That's the primary problem, and it's not just on convincing people to do it. It's also we need the money to be able to do the research that we can translate it.
I would also say information. That's one of the reasons our project has focused on providing basic information about material ingredients and relating that to known health hazards, is that there's very little information available about the chemicals that are used to make the building products we rely on. And so we know from our research a lot more information than is available to the average specifier or building owner who's trying to build a healthy building. Take, for example, the incredible efforts that are being made to associate a healthful environment with reduced incidences of asthma in children, especially children who are living in low-income environments. And at the same time, so the parents might be being provided with HEPA vacuums, they might be being told about reducing the use of fragrances like air fresheners and things like that in the environment. But meanwhile, the apartment or home is outfitted with vinyl floors and carpeting and a lot of building products that are known to have asthmagens that are released into the atmosphere of that home. And for somebody who's looking at criteria like, say, smooth wipeable surfaces for other health reasons, to reduce mold, for example, they don't realize that among those choices of smooth wipeable surfaces are some products that contain chemicals that are associated with, that are known to be asthma triggers, and some don't. So just having that basic information available can go a long way in terms of really, targeting the most effective interventions to some of the health issues that we're trying to address. And right now, it's very difficult to get that information. And when you do, it's very difficult to compare one product with another because obviously it's in a marketing context, information is presented in its most favorable light. So we need the standard formats, the standard definitions, and the standard measurements, and good database tools to allow people to compare that information and make informed choices.
And I'll just add to it because Charlene talked about money as a barrier, right? Bill talked about information. I'm going to add to that timing, right? So this conversation needs to be starting way in advance before we design these environments. Oftentimes we come in too late and the building's going up. And it's hard to be part of that conversation when it happens too late. So timing is huge that we're part of this conversation. That's up to the people in this room to talk to people that are part of these projects to look at the timing. And the other thing that I will say to Bill's point is empowerment. So not just that you take the information today, but you know exactly what question to ask. And you feel empowered by the science behind it to be able to ask that question at the right time on the projects and initiatives that you are working on.
And that all comes back to another theme for today is language. How many different disciplines, how many physicians we have in this room? How many chemists do we have in this room? How many engineers? How many architects? Can y'all talk to each other? Do you know if the engineer goes to the doctor, can you communicate in a way that can tell you how to put that building together or what's going on? Not very well. That's a gigantic issue. And so that's a barrier that we can actually work right now to overcome.
All right, folks, we have 4 minutes, and we have Stephen and Carl.
I just want to say one sentence.
Real quick.
The problem is physicians don't know this. The AMA said 19 years ago that chronic fatigue doesn't exist. Academy of Sciences said Gulf War syndrome doesn't exist. 17 years later, they finally changed their mind. Bringing people up to current speed of where the research is to clinicians will then be able to change policy. Doctors are holding us way back.
Okay. Right. Stephen?
Hi, I'm Steve Waller from Uniform Service University across the street, and I want to comment on your comment, Whitney, about timing, because I think so many of these decisions are made on our counting cycles of fiscal years, quarterly budget reports, and many of these decisions are made much more intelligently if we take a long view. You may know the Iroquois Indian tribe, whenever they sat down to make a significant tribal decision, considered the impact on 7 generations hence. We don't do that in this society, largely because our incentive structures are built on making a profit this year. So I think that's a big part of your communication challenge. The other comment I'd say is I think it's more than translation. You may know that's a fairly simple term that just means taking one word and changing it into another word that somebody else understands. I think it's hermeneutics, which implies all the cultural overlay, all the body language. It's a much more nuanced term, and translation is a little too simple. going from one to the other. I think it really is hermeneutics, so I'd appreciate your thoughts on those 2 points.
Thanks, Steve.
I'm learning from you. Those are amazing comments. Thank you. On the first comment about the economic cycle, working with hospitals, a really big challenge is they are owner occupied, right? So they're going to be around and they're very concerned about what's happening with their patients and their staff. My problem is that it's a facilities budget. It's taking the building up, and it's the risk group that's going to monitor the safety, and it's going to be looking at issues around infection. And those two people, unless there is a very top-level person involved in the project, may not understand those two budgets. And then in the end of the day, what happens is those cycles run too quickly, and facilities doesn't have the power, I think, at times, to be able to speak across and say, I invested more here in a product. You nicked me because I was over budget, but it showed up because we were able to reduce whatever, a fall in the environment or, reduction in infection spread over in the risk group. So I'm very after if anyone in this room, I'm like, show of hands, has an economic model that we can start to bring into some of these conversations with building owners about here's actually how you're going to be able to track the outcome of this investment longer term. So I think that's a huge, huge issue. And on the second point about, Charlene's like, shut up.
I said they wanted. We're out of time.
Okay. Well, I'll take the cue from the audience.
Carl Grimes with the Indoor Air Quality Association and Hayward Healthy Homes. And I'd like to add another factor, and that's residential, not just commercial buildings, and the people. I mean, we talk about people, but we don't talk about me and you and the occupants of those buildings, particularly from the point of view of this is one of the obstacles and the challenges. My house is my house, and I'm the master of my house, and don't tell me what to do about my house. So we have a huge obstacle there to educate them in a way that they can start looking at it and say, maybe I ought to consider what's going on in my house, and then maybe they can also consider what's going on at the office.
And the last comment, since Charles isn't here to hook me, NIH needs a department in this area to bring clinicians and researchers together, or NIEHS, so that we can bring the information to the public. But right now, this is the first time that anybody, representing environmental physicians, has ever spoken at one of these meetings, besides Claudia Miller in the last couple of decades. Thank you.
Okay, thank you, everyone. We're going to take a 5-minute break before our next session. And the way we're going to do it is that I will come back again in 5 minutes and introduce the next group and give you a little bit of a heads up on what they're going to be telling you about. Thank you all.